Thank you guys, everyone, for joining us today. My name is Julia Maeta, and we are pleased that you could join us for our fourth lecture of the 12-week didactic series. This series brings you lectures from experts in the field covering different topics each week. The Neuropsychology Didactic Series was created by trainees and early career neuropsychologists to provide free, high-quality didactic opportunities for the international neuropsychology community. Next slide, thank you. Next slide, we have our disclaimers for the series. Oops, sorry, our financial support. So we would like to thank our generous sponsors for their support of the Neuropsychology Didactic Series. These sponsors include APA's Committee for Early Career Psychologists, or CECP, and the APA Graduate Student Committee, or APAGS. We also want to thank the Association of Postdoctoral Programs in Clinical Neuropsychology, the International Neuropsychological Society, and the Society for Clinical Neuropsychology, or APA's Division 40, for their financial support. On the next slide, we have our disclaimers for the series. So this training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own and do not reflect the official endorsement of any institution or organization. Questions for our speaker today can be submitted via the Q&A box on the lower left of your screen next to the chat. We will address questions submitted to the speaker during the last 10 minutes of the talk, and a recording of today's lecture will be posted later this week on the Know Neuropsychology website. Now, next slide, please. So just a couple of tips and tricks. So if you are having trouble hearing us, you can click the Join Audio button on the lower left of your screen next to the microphone. Using the Q&A feature will help us keep the chat quiet while we collect questions for the moderator, and a recording will be posted. Now, next slide. All right, without further ado, it is my pleasure to introduce Dr. Alexander Tan for today's lecture on integrating the scientist-practitioner perspective into clinical practice. Dr. Alexander Tan is a pediatric neuropsychology fellow at Children's Healthcare of Atlanta. He completed his PhD in clinical psychology and internship in neuropsychology at the University of Texas Southwestern Medical Center and Children's Health. He will be starting his career in the fall as a faculty member at Children's Hospital Orange County. His research interests include differential neuropsychological sequelae of pediatric demyelinating diseases, congenital heart disease, concussion, and rare genetic disorders. In addition to being a Know Neuropsychology committee member, Dr. Tan serves as the chair of the Asian Neuropsychological Association Student Committee and is involved in research and advocacy for culturally sensitive neuropsychological assessment in Asian populations. And thank you so much.
Okay, thank you for the introduction. I'm excited to be a part of this initiative and to talk to you all today about something that I've been considering throughout my training process, which is how to practically integrate the scientist-practitioner perspective into my clinical practice as a future neuropsychologist. So in my mind, I'm speaking to two audiences today. On the one hand, this is a relatable topic to everyone here as we all strive towards integrating theory and practice in our clinical work. But I'm also speaking especially to those of you that are in training. For many of you, my background might sound familiar. I'm not a research expert by any means. I come from training programs that are primarily clinically focused with a lesser emphasis on research requirements. And my goals for future practice have always been clinically oriented as well. But because active research collaboration throughout my career is also a personal interest and career goal of mine, consideration of this topic as a trainee has been important for my development and has helped me demonstrate ongoing research productivity and publication throughout my training. So my hope is that my experience will be helpful to all those that are going through the same process of learning how to integrate research into their clinical practice, and especially trainees that may find themselves coming from a similar background. So I have no financial disclosures to report. And As I will be highlighting various research projects specifically throughout this talk, I just wanted to acknowledge my collaborators on these studies right from the beginning. It has been a pleasure to work with all of these wonderful supervisors and colleagues, and I'm very grateful for their collaboration throughout my training. So learning objectives for today: describe the process of developing an integrated scientist-practitioner perspective, learn how to apply the integrated scientist-practitioner perspective to professional practice, and identify practical strategies for integrating research and clinical work throughout neuropsychology training. Kind of an overview of today's talk. I'm going to start with some background on this idea of developing an integrated scientist-practitioner perspective. I'm going to use my experience in clinical work and research with pediatric demyelinating diseases as kind of a case study to illustrate this, provide some additional examples of integration with clinical practice, and provide some practical strategies for integration throughout training. Okay, so starting with some background on the scientist-practitioner perspective. So this model that you see here on the left is a conceptualization of my personal experience of the process of developing an integrated scientist-practitioner perspective throughout my training, from exposure to assimilation to application to integration. The literature is very limited on this developmental process. There is no framework that I'm aware of regarding this development in the literature. So as a disclaimer, I'm not using an evidence-based model here, which I realize is ironic given the subject of this talk. But I do want to spend some time to delve into the literature on each of these steps and some of the obstacles that the field faces along this pathway. So to start, while we're jumping in here, I'd like to ask a few polling questions of the audience. So hopefully this works, but I'm going to switch over to a poll. Give me 1 second. Okay, so everyone should be able to see that. You can join by scanning the QR code or joining at the website and entering the number there. Just give everyone a few seconds to join. I'd like to ask that you respond only if you're currently in training, so any kind of student or intern or fellow. Okay, so I'm going to go ahead and activate the first poll. How well has your program integrated both science and practice within your training? Excellent, adequate, not adequate, poor. This is completely anonymous, so feel free to be honest. Seeing the results roll in. Okay, it looks like it's stable. I'm just going to write down these numbers, but it looks like we have 40% reporting excellent training, close to 50% reporting adequate, and then we have close to 10% reporting not adequate. Okay. All right, going to move on to the next question. Thank you for your responses. Okay, question 2. How confident do you feel about your ability to integrate research with clinical work in your future practice? Very confident, somewhat confident, not that confident, not confident at all. Okay, I'm just going to write down these percentages. So looks like very confident, we have about 29%, somewhat confident, 52%, 16% not that confident, and 3% not confident at all. Okay, thank you for your responses. One last question, question 3. How often are you currently integrating research-based decisions when working or communicating with patients clinically? Almost always, often, rarely, sometimes, or rarely. Okay, I'm gonna write down some of these percentages. So we have about 30% at almost always, about 47% at often, 21% at sometimes, and 3% at rarely. Okay, so we can see just with this sample that we do have many of you that are reporting kind of excellent to adequate training in terms of integration and confidence, as well about future practice. And then we see that higher percentages, once we ask about current integration, it's skewed a little bit more, that there's more people reporting sometimes and rarely as well. So this helps me get an idea of kind of my audience. I know, many of you who are attending today, you are ones that take initiative to attend didactic experiences such as this. And I imagine that this sample might look a little bit different from others reported in the literature. But I'll bring this up in a little bit. So let me switch back to my slides here. Thank you again for your responses. Okay. All right. Okay, so first stage in my mind is exposure. So exposure to the idea or theory that clinical work and research can be integrated. Exposure usually starts in training, as many programs have adopted the Boulder model. So the Boulder Conference in 1949 is considered the beginning of the Scientist-Practitioner model of graduate training, having as its aim an educational model that would integrate both science and practice within the student's training experience, and creating an environment where equal emphasis was given to both to develop a more well-rounded clinical psychologist. So APA Division 12 has, I think, a good definition. Clinical psychologists are educated and trained to generate and integrate scientific and professional knowledge and skills so as to further psychological science, the professional practice of psychology, and human welfare. But even at this first step, debate has ensued regarding the degree to which the Boulder model actually results in integrated training. So skeptics argue that one's interest in and talents for research may be incompatible with their interest and talent for clinical work. So this has led to inconsistent exposure across programs. And the Vail Conference in 1973 de-emphasized the scientist-practitioner model in favor of a practitioner-oriented approach to training programs, which is adopted by many programs today. And additionally, in many programs that do follow the Boulder model, clinical work and research are often parallel processes as opposed to an integrated model of training, which points to a concern regarding validity, that the model might not actually help students learn how to integrate science and practice. So this has implication for neuropsychology students, most of which attend clinical psychology programs, who at the beginning of their training face a significant variability in exposure to the integration of science and practice. So the next stage is the assimilation stage, which is the internalization of the scientist-practitioner theory that your clinical work needs to be evidence-based and should also contribute back to science. So you start to consume and produce research with purpose. And this process generally happens during training. And for many, this is a dissertation process. So studies show that students are generally satisfied with receiving a scientific-based training model, report good ratings of quality and quantity of training opportunities, and have confidence in their abilities to apply the scientist-practitioner perspective to research and clinical work. I think this is consistent with what our polling for the audience today showed as well. However, there are limitations at this stage. Being trained does not ensure consistent application. We saw that a little bit with the polling question, the last polling question asking about current integration of research-based decisions in the clinical practice. And actually a study by Van der Veen in a sample of 653 clinical psychology graduate students showed that despite understanding the ways in which science can influence practice, over 1/3 of students were reporting that they were actually rarely using science-based decisions, so that's 0 to 25% of their cases, when informing clients of the clinical services they were providing. So other challenges include there being a diminished quantity of research opportunities due to increasing number of accreditation requirements that some programs face. Some programs report being unclear as how to best train students so that the skill sets for both research and practice remain competent, but still have influence on each other. And without training and integration, there's this idea that science often holds the weight of indirect relevance to clinical work. So there's a trend that students may want to be competent in science hypothetically without actually wanting to emphasize research during their graduate education and future practice. So the implications of these results from these studies support the need for a more detailed evaluation of clinical psychology graduate students and their use of research-informed practice, and the extent to which graduate students are being trained to integrate these skills. So the next stage I think of as the application phase. So the application of the scientist-practitioner model as a principle. This includes the provision of evidence-based clinical services and producing research that leads to the growth and development of professional practice. There are actually some that argue that the application of the scientist-practitioner model is actually us meeting an obligation to our patients, and that the current professional climate necessitates our renewed commitment to the scientist-practitioner model so that we might distinguish ourselves from colleagues in medical, educational, and social work settings. So while application of the scientist-practitioner perspective is the goal on paper for any neuropsychologist, current professional practice does create many obstacles for reaching this stage. So for example, some argue that the scientist-practitioner model is often incompatible with professional practice and can rarely be fulfilled. This is due to a thought that there's differing priorities. So the scientist is concerned with knowledge that is rigorous, objective, and generalizable, while the practitioner is concerned with knowledge that is subjective, holistic, and applicable to the individual. We also see that day-to-day application is rare. Changes in the healthcare system, diminished funding for psychosocial research, decreases in tenure-track faculty positions. This all leads to new models that are needed for integration of clinical practice and research productivity along practitioners. We also see that there are monetary contingencies that work against the unstructured, creative time often needed to produce research. And some are also faced with logistical barriers as well in these settings that impede robust involvement in research activities, such as lack of access to an IRB, journals, or research assistants. And finally, many psychologists are unlikely to engage in research once qualified, as they simply rank research as a lower priority. So many psychology careers require little or no research productivity as part of their professional requirement. So these challenges have implications for neuropsychology trainees who may be on internship or fellowship, as these obstacles often create barriers that impact the ability for training programs to provide trainees with quality research supervision, also protected research time, or meaningful research opportunities during their training. So I see the final step as integration. Integration of the scientist practitioner as not just a principle, but a perspective, which can influence all areas of professional practice. And there have been various models in the literature that have offered suggestions that would help to bring science into a position more valued by practitioners. So for example, Stricker's local clinical science model is based on the idea that science is defined by attitudes, non-activities, which can vary widely from discipline to discipline, or generalizations, which can become outdated quickly. And he defined 4 characteristics or 4 qualities of the local clinical scientist. So displaying a questioning attitude and searching for confirmatory evidence, producing research as a natural response to practice, applying research findings directly to practice, and undertaking evaluation of individual practice. Crane and Hafen in the literature also emphasize that the scientist practitioner should be concerned with integrating the consumption and production of research with a distinct professional identity. So many of us have had the experience of identifying research studies that resonate with our own practice or shape our views about practice, or experiences of conducting research that shape our outlook on the services we provide. Thus, being a scientist practitioner becomes part of our professional identity. Corey and Callanan found marked variations in how the scientist practitioner model was being defined, and they argued that it should no longer represent a single way of working, but comprise more idiosyncratic definitions, so changing from a model of practice to a system of values. And Menafee found in the literature that higher levels of endorsement were associated with viewing the approach as an integrative tool that permits the use of a range of methods and outlooks on knowledge, which promotes a mutually informative relationship between science and practice. So for many competencies in neuropsychology training, if you think about various competencies, integration represents the highest stage. So for example, integration of the patient medical history with test results when we're making clinical interpretations, integration of knowledge of brain behavior relationships when we're writing reports. Likewise, providing trainees with opportunities for integration of the scientist-practitioner perspective, particularly during the fellowship stage, can allow neuropsychology trainees to reach the highest level of competency in integration of research and clinical practice. Okay, so I want to provide a practical example of how I went through this process using my personal line of clinical work and research in pediatric demyelinating diseases as kind of a case study. So I started graduate school at University of Texas Southwestern Medical Center in 2014, and I got involved right away with the Children's Health Pediatric Demyelinating Disease program, which had just opened in 2009, 5 years prior to my arrival. It was a very special clinic, which represented a multidisciplinary approach that included neurology and neuropsychology, among many other disciplines. And the beginning of my time in the Pediatric Demyelinating Diseases program represented to me the exposure stage, where I started working with patients clinically and helping with research studies, and found that there was a culture of combining clinical work with the consumption and production of research. So I want to give you a little bit of background for those of you that might not be familiar with demyelinating disorders. You're getting a bonus mini didactic today. So central nervous system demyelinating diseases occur on a spectrum with differences in areas affected and disease course. And while the literature on adult populations is a lot more developed, studying these populations in children is important because these differences may differentially impact the developing central nervous system. And so among the most well-studied conditions, we have multiple sclerosis, or MS, a relapsing inflammatory autoimmune disorder of the central nervous system with clinical features including almost any neurological symptom, depending on the disease target. We have acute disseminated encephalomyelitis, or ADEM, an inflammatory demyelinating condition affecting the central nervous system, manifesting as an acute onset encephalopathy associated with polyfocal neurological deficits. We have neuromyelitis optica, or NMO. This is inflammation and demyelination of the optic nerve and spinal cord with associated changes in vision and mobility. And finally, transverse myelitis, or TM, a monophasic inflammatory demyelinating condition of the spinal cord with clinical features including resulting motor, sensory, and autonomic dysfunction. So in the literature, NMO and TM were widely thought to be associated with this quote-unquote idea of relative sparing of the brain. But in our clinic, they were commonly presenting with neuropsychological difficulties. So it became unclear to me how to really assess these populations. And so this is where I started the assimilation process. Because I started generating my own questions in response to my clinical work, this led to this internalization of the scientist-practitioner theory that my clinical work needed to be evidence-based and should be contributing back to theory. So I began consuming research with the purpose of investigating the presence of neuropsychological difficulties in these populations so I could practice in an evidence-based way. So in the process, I found the research was extremely limited and scattered. There was nothing easily accessible in the world of pediatric demyelinating diseases. So to inform my clinical practice, I initiated the idea of writing a literature review. I'm going to share some of these pulled together findings from the literature. Multiple sclerosis is easily the most well-researched. So in pediatric populations, we see that about a third are presenting with cognitive impairment, but these neurocognitive profiles are still heterogeneous. 50% are presenting with psychosocial difficulties, and 75% are reporting fatigue. So in ADEM, the literature suggests that there's the presence of cognitive and psychosocial difficulties with the ADEM population when compared to both healthy control and multiple sclerosis groups. but this literature is rather limited. In NMO, the presence of neurocognitive deficits have been observed in adult populations, but no studies in pediatric samples have been conducted. So our lab conducted one that we presented at NAN in 2015, and we found in that study that there were similar deficits being observed in our pediatric sample. And finally, with TM, I really found that with the transverse myelitis group, research had only recently begun to reveal the unique experiences of pediatric patients with TM, including allusion to cognitive and mood difficulties in the literature, and really only one published study thus far which had directly evaluated neuropsychological functioning in pediatric transverse myelitis. So the investigation of neuropsychological outcomes in this population is limited, probably due to the rarity of transverse myelitis and the restriction of the condition to the spinal cord. But I found that emerging research was raising questions about the possibility of brain-based pathology in transverse myelitis, despite the absence of obvious cerebral involvement. So here we had a transition to the application stage. Applying the scientist-practitioner model as a principle, I felt that I needed to not just consume research so that I could be providing evidence-based services, but also to produce research that could lead to growth in the practice of myself and my field. So I was fortunate that due to the structure of my training program, my internship and my dissertation processes were actually very much interrelated. And I was able to do both of those things at the same time, which really pushed for my development into this stage. So for my dissertation, because literature focused on pediatric MS was constituting the majority of what is known regarding neuropsychological outcomes in these populations, I aim to use it as a context for comparison with neurocognitive and psychosocial outcomes in pediatric transverse myelitis, where cerebral involvement has been alluded to, but very little is known. So in the application phase, it is easy to develop research skills due to there being an applied purpose for learning. So my research skills really developed as I created the master database for the lab, assisted with data collection, and really taught myself various statistical methods, including profile analysis, which was the methodology used in this study. We ended up with a sample of 69 pediatric multiple sclerosis patients and 55 with transverse myelitis, who all completed neuropsychological screening evaluations as part of their routine clinical care in a multidisciplinary setting. They were all at least 30 days from acute symptom onset or steroid treatment, given the cognitive implications found in the literature. And I shared my preliminary findings at INS in 2018. I want to share some of those findings with you today as kind of an illustration of this process. So just to orient you, this is the neurocognitive profile analysis. We see here the main profile plot. We have the MS group in blue, the TM group in green, and all data were converted to standard scores, with higher scores indicating better performance. So here you can see our key variables included the CBLT for verbal learning and memory, digit span for auditory attention and working memory, the symbol digit modalities test for processing speed, FAS for the verbal fluency, the trail making test for attention and cognitive flexibility, VMI for visual motor integration, and the groove peg board for fine motor functioning. So the test of equal levels found that overall performance was significantly lower in MS compared to TM, which is what we originally hypothesized. But the test of flatness showed that difficulties with motor-based tasks were the most significant contributors to their combined profiles. So this had some implications for our battery. And finally, the test of parallelism showed that there was no significant difference found in profile patterns between these groups. So this was actually contrary to our hypothesis, and this indicated that the TM sample, while less impaired overall, displayed a pattern of relative neurocognitive weaknesses, which was similar to what was found in the MS sample. And so there was some additional context for this finding through preliminary analyses investigating frequencies of impairment in a TM sample, as higher than expected rates of impairment were found in many of these domains, with similar distributions in the frequencies of impairment found in the MS sample as well. So here we have the psychosocial profile analysis. Just to orient you again, the main profile plot here We had measures including the BRIEF, the BASC, and the PEDS-QL, the Pediatric Quality of Life Inventory, as measures of executive, emotional, behavioral, and quality of life functioning based on parent report. All the data have been converted to standard scores, with higher scores indicating less distress. For all you pediatric people, anyone that uses these measures, this might require a little bit of cognitive flexibility because it's been reversed from how they're normally scored. But we have here the test of equal levels showing that no significant difference was found in overall ratings between multiple sclerosis and transverse myelitis groups, which was indicating that these groups are being rated by parents to experience similar levels of overall distress, which was inconsistent with our original hypothesis. The test of flatness showed that no measures were found to be significant contributors to combined profiles, indicating that all variables were contributing variables. I will say here that there was a trend towards significance, so fatigue, academic difficulties, and quality of life did approach significance in our analysis. But the most interesting part, the test of parallelism here showed that there was a significant difference found in profile patterns between groups, which was characterized by higher parent-rated difficulties with functional problems with cognitively associated tasks, so working memory and attention, in the MS sample, while the transverse myelitis sample displayed more parent-rated difficulties with physical quality of life and social problems. So these results are really important for our transverse myelitis population, as it validates their problems in a rare disease that really hasn't received much attention. Okay, so I go through all of these findings not to kind of delve too much into the details of the statistics or the results, but really to kind of illustrate this process of development of this integrated scientist-practitioner perspective. Because somewhere along the line, as I learned to take the characteristics of the local clinical scientists of displaying a questioning attitude, producing research as a natural response, applying research findings directly to practice, and undertaking evaluation of my own individual practice, there was a transition from applying the scientist-practitioner principle in my work with this population to this integration as a perspective into my professional practice. So to illustrate this, I want to share some ways in which these findings directly shaped clinical practice of the field, as well as my own individual practice. So results really supported that that neuropsychologists play an important role in the assessment and treatment planning for these populations and should be included as part of any multidisciplinary team for pediatric patients with central nervous system demyelinating diseases, including those without obvious cerebral involvement. These contributions to our transverse myelitis program really helped provide a standard of care for the nation, which included implementing consistent neuropsychological screening of transverse myelitis patients to detect neurocognitive difficulties, investigate the impact of psychosocial problems, and inform tailored educational and treatment planning. And on an individual level, in a field where diagnoses can sometimes be unclear, my knowledge of neuropsychological profiles has actually at times helped me contribute to diagnostic clarity and interdisciplinary communication with other providers. So results also suggested that neurocognitive difficulties found in pediatric TM patients may not be expected when compared to pediatric MS patients, despite their similar patterns of relative weaknesses, and that psychosocial difficulties may not be anticipated in TM, despite similar levels of reported overall psychosocial problems and reduced quality of life. So it became important to communicate directly with clinicians and other team members to take their concerns seriously and address them clinically, and to include similar interventions in their treatment planning. On an individual level with my own patients, as I recommended educational services, therapeutic interventions, and supports for fatigue, I felt that I was able to really meet the need of these families in an evidence-based way. The results also had direct applications to our clinical battery to streamline the screening process. This was particularly important for those that were being assessed using teleneuropsychological methods. You may have heard more about Dr. Lana Harder's work in this area in her recent INS webinar on teleneuropsychology during the period of COVID-19. If you haven't, you should check it out. On an individual level, when others consult with me regarding cases in these populations, I really feel I'm able to use the opportunity to talk about battery selection in an evidence-based way. So that includes considerations such as the use of symbol search over coding, or the sensitivity of the simple digit modalities test that has been validated in these populations. We also saw changes to how we were educating families regarding neurocognitive and psychosocial issues, which we found was validating many of their concerns that were previously not being addressed given the lack of regular integration of neuropsychological screening. And on an individual level, I was grateful that my results could be shared at the annual transverse myelitis summer camp, and these results were well received by patient families. And finally, during my fellowship, I have been able to apply this research to the neuropsychology department's practice while I've been at Children's Healthcare of Atlanta, as I personally got involved with program development and contributed to the initiation of a neuroimmunology and multiple sclerosis clinic in collaboration with a neurologist and other neuropsychologists. So this involved helping to implement logistics of practice for the clinic, including the use of a streamlined screening battery that was a result of my past research, assisting with creation of training opportunities, and contributing ideas for research directions that evolved into a new study, which we have since submitted for publication. Okay. So that was kind of my experience with pediatric demyelinating diseases as a case study to kind of illustrate this development of the integration of the scientist-practitioner perspective into clinical practice. For the purpose of giving you some more ideas and food for thought for how you can apply this to your own training, I want to provide some additional examples that I experienced throughout mine. So one way that this could look is working with a patient and finding a gap in clinical practice and disseminating knowledge of your case to help shape clinical best practice. So in this example that I experienced, I had a patient, this was on internship, that was a 13-year-old male with Pitt-Hopkins syndrome, which is a very rare genetic disorder and usually presents with severe intellectual disability, absent speech, motor delays, and features of autism spectrum disorder. So in his case, he was not diagnosed until age 12, so 1 year prior to the evaluation. And he was demonstrating abilities beyond what has been detailed in the literature. So that included use of full sentences, capacity to learn and solve novel problems, basic academic functioning, and independent ambulation. And so our evaluation was actually the first neuropsychological evaluation reported in the literature for this population. And we used our case study as a platform to demonstrate a spectrum of abilities beyond what was documented in the literature, and as a call to more consistently use more comprehensive forms of genetic screening. So that included whole exome sequencing as opposed to chromosomal microarray methods, so that we could have more accurate diagnosis and treatment and better treatment outcomes. This might also look like coming up with a question while working with the population, helping to fill in the gaps in the literature, and then modifying your own clinical practice in response to research. So for example, as me and my colleagues worked with adolescents with sports-related concussion, we started to ask the question of whether or not there were differences between their path to symptom resolution and those with concussions from other sources. So this work was really a result of my collaboration with my colleague, Dr. Kristen Wilmuth, and her dissertation process. And in this process, we wrote a literature review to help fill in the gaps in the literature, and then conducted studies in our own samples to answer the questions ourselves. And so you may have seen some of Dr. Wilmuth's work. She's presented many of her findings at national conferences and won multiple dissertation awards for her work. But one particular study found that the generalized anxiety disorder screener was a significant predictor of prolonged recovery. And since then, I've personally made sure to include anxiety screeners in my own assessments and emphasize this with patients and families in my clinical practice. And one final example, this integration may look like responding to observations in your clinical work, taking the opportunity to use research to evaluate your own practice, and then using the results to influence program development. So during my congenital heart disease rotation on my fellowship at Children's Healthcare of Atlanta, my supervisor and I started noticing a higher rate of concern for autism spectrum disorder than what would be expected from the general population. So we decided to conduct a study to evaluate this. And the results that we found were that there was a significantly higher rate of risk for autism spectrum disorder, independent of risk factors related to birth or neurological complications. So we presented these results at INS and we've submitted for publication, but we've been using these results as an opportunity to influence program development. So on a departmental level, really changing our clinical practice to include autism spectrum disorder screening when we assess children with congenital heart disease. On a regional level, increasing interdisciplinary collaboration and training with autism experts, especially at our local Marcus Autism Center. And on a national level, supporting the implementation of standard screening procedures for autism spectrum disorder in this population across national cardiac neurodevelopmental programs. Okay. So hopefully those additional examples provide you with some kind of food for thought for how you might integrate this into your own training and your own practice. With my final remaining time, I want to provide some practical strategies for this integration of research into clinical practice. So to start off, for those of you that are trainees and early career professionals, these suggestions have been consolidated from me talking informally with various faculty members that are regularly engaged in research. And so I've kind of consolidated those suggestions and guidelines here. Probably the most common thing that I heard was related to time being the biggest barrier for practical integration. So I heard different strategies related to time management. So that includes protecting research time. For some people, that means setting aside a full day for research as opposed to just working on research if your patient doesn't show up, because it really does take a while to kind of get into the mindset. Different strategies for creating boundaries, such as avoiding the research or closing the door so as to limit. I heard some strategies around efficiency, so really emphasizing collaboration with colleagues, using research assistants, and participating in writing groups. And I heard different things related to accountability as well. So some emphasize that it's really important to set deadlines. Otherwise, it can be easy to put things off because there's always something you can find to do that will get in the way. Many find that working with fixed deadlines, such as conference abstract deadlines, or grant deadlines, can really be a helpful motivation as well. So I also heard some strategies around this idea of thinking about research while you practice. So this might look like, for example, when a question comes up while working with patients, generating some theoretical hypotheses, and even just using your clinical work with the same patients in the same population for some initial testing of these hypotheses. Also, keeping the door open for future research questions. So we think about this, especially in our battery selection. If we use a standardized battery with a certain population, or for example, integrate an extra task into the battery that can be used for research purposes down the line. The idea here is that hindsight is always 20/20 afterwards. And one additional suggestion I heard was really taking some time to make sure you have an organized patient database when you're keeping track of your patients clinically. That includes diagnoses, dates of service. This can really be handy if you decide to do a research study and need to do retrospective chart reviews, which is very often a practical way of doing research as clinicians. And so really kind of making sure that we have an organized database there, which can save a lot of time and frustration later. Also, if creating a research database, if you've actually initiated a study, really spending the adequate time in the beginning to think through your variables and how you are coding them so that they are theoretically and statistically relevant. And one last area of guidance that I heard quite frequently was just this idea for the trainees out there that research opportunities really can be created, especially while you're a trainee. So that includes things like increasing your competencies, didactics, self-teaching on various research skills, including different methodologies and statistical methods. I know the Known Neuropsychology Didactics series has a research line in this regard. Also fostering relationships. So fostering relationships with supervisors and colleagues who may be future collaborators. And in many cases, faculty members are actually very open to student interest. So don't be afraid to approach faculty members and ask about research opportunities that might be available to you. And finally, I've found from personal experience, writing literature reviews is really a great entryway into research, especially when you're kind of doing a literature review in regard to a specific topic or population. It really results in this thorough exploration of the literature, which can really offer some insight into future research directions that you might want to explore. Now, I also want to provide some additional strategies. You know, the neuropsychology training timeline, I feel, overlaps quite well with this developmental process of developing an integrated scientist-practitioner perspective. So for training program directors and supervisors, these ideas have been consolidated from talking informally with various trainees. And if you are a trainee, then you may find that these ideas are helpful to advocate for within your own training programs or with your supervisors. So when students are interested in pursuing graduate training or they're early in their training, they do require increased opportunities for exposure to really generate interest in research. So something helpful that I experienced in my program were these regular quote-unquote research snapshots where different faculty members presented on their research to really model integration of science and practice and promote interest in various research studies. Also, oftentimes we allow students to shadow clinical providers to increase their exposure to clinical work. So it can be helpful to provide the same kind of structured opportunities to allow students to observe and participate in various stages of the research process as well. So in the congenital heart disease study that I mentioned earlier, one of the authors is actually someone currently applying to graduate programs with very limited research experience. So I was able to really increase his exposure in a significant way by allowing him to observe me in all the stages of the research process sequentially. So letting him participate in the literature review, data collection, analyzing the results, and then helping to create and present the poster, and then providing feedback for the manuscript. So at the assimilation stage, promoting development of research skills can be very important to provide educational opportunities beyond minimum standards in different training programs. So this may mean being mindful of integrating research-specific elective courses or didactics into curriculums or seminars. Also promoting development of evidence-based clinical practice. So many have mentioned that they have a larger appreciation for their clinical rotations when provided with regular literature review or readings, and then having opportunities for discussion with supervisors. So for example, integrating a book into the rotation with time and supervision for discussion of a chapter each week. Yeah. So at the application phase, to promote bidirectional application of science and practice, it can be helpful for supervisors to model this when working with trainees. So particularly during the dissertation process or at the internship level, for example, discussing what hypotheses might be generated to explain observed clinical features and using future clinical work as an opportunity to test some of these hypotheses, or allowing trainees to participate in rotations with supervisors that are conducting research in their clinical populations of interest and integrating this research participation into their supervision process. Also discussing how research findings can be applied to improve clinical practice. So whether that be from studies in the literature or the supervisor's own research, and really finding opportunities to model this thought process for trainees. For example, oftentimes trainees are required to give case presentations. So these might be an opportunity to integrate findings from the literature and to kind of talk about clinical practice in an evidence-based way, as opposed to just simply being an overview of clinical details of whatever the individual patient might be that they're presenting on. And finally, my feeling is that the fellowship stage really offers a unique opportunity to promote integration of the scientist-practitioner perspective. So especially for training programs that are primarily clinical, like mine, setting aside time to discuss research questions that have been generated from working with patients and how they might be answered using research methodology, and encouraging trainees to evaluate individual or departmental clinical practice based on either their review of the literature or research that they're involved in. And additionally, oftentimes research participation is limited to joining studies that are already established and not really requiring independent thought as in the context of being a response to your own practice. So it would also be helpful to encourage trainees to complete independent research projects to really answer research questions that they generated in response to their own clinical practice, with the supervisor supervising on each step and being open to learning with the trainee regarding new methodologies or statistical methods that might be required. It would be helpful to be mindful of, for example, starting fellowship with a relevant rotation or a supervisor that could give the trainee adequate time to develop such a project. And so that might mean kind of thinking about what rotation the trainee starts with as they enter their fellowship process. Okay. So I'm doing great on time. I want to provide enough time for questions, but just some concluding thoughts, some take-home points. The scientist-practitioner model is not just a principle, but a perspective which can be integrated into our clinical practice as an attitude, as a value, and as a tool. So really, this might not be so attainable when we think of being a scientist practitioner as a requirement in our practice, but it really becomes valuable when we take it as an attitude of being keen observers who are characterized by disciplined inquiry, critical thinking, and openness to change in the face of evidence. The neuropsychology training timeline really offers an opportunity to cultivate the development towards an integrated scientist practitioner perspective. As I've progressed through my own training, this idea of the integrated scientist practitioner perspective has really helped shape a lot of my clinical work and has influenced all parts of my professional practice, including program development and training. And so it's a perspective I plan to take with me as I move on to the next phase of my career. And finally, this integration is most valuable as part of our professional identity and can enhance all areas of our professional practice. So I hope that this talk has provided some food for thought for each of you to consider how you might allow this kind of perspective to influence your clinical practice and your professional identity. Okay. And so thank you for taking the time to listen to my talk today. Before we jump into questions, just want to say to please join us again next Monday. Dr. Veronica Bordas-Edgar will be presenting on neurodevelopmental disabilities, risk factors in pregnancy and birth. And with that, I'm open to take questions.
Awesome. Thank you so much, Alex. Let's go ahead and do a couple of the first questions are based on if you work at a clinical site that is primarily focused on clinical work. So how do you recommend pursuit and integration of a scientist practitioner model when transitioning to positions that involve only clinical work? For example, where there is not an ethics committee that is available at the center.
Mm-hmm. So this really gets to what I was kind of mentioning earlier. I totally empathize with that experience, right? So I, as well, am kind of in a clinical fellowship, and you know, there is kind of a stated kind of minimum percentage of time that's dedicated to research and training and professional development activities. And many of you might kind of find yourself in a similar situation where even though on paper there is that kind of 10% or whatever the time might be allotted to that, your clinical responsibilities really tend to kind of fill up your time. And it's really what's emphasized by your supervisors and by the training programs. So this was kind of my case at Children's Healthcare of Atlanta. There is kind of a minimum research requirement and a minimum kind of percentage of time that's on paper dedicated to research. But I really found that kind of using this, having this integrated attitude and perspective is really what allowed me to maximize my research experience. And so earlier I used the example of my congenital heart disease rotation. That was a 6-month rotation that I did in my first year. And really just coming in with that kind of integrated perspective in response to working with patients and generating some hypotheses, and then really taking the initiative to develop a study that was in the context of my clinical work. Of course, it took additional time after the rotation was over, but really having it been generated from my clinical work and having it being built into my rotation and kind of in the context of my supervision as well with my supervisor at the time, really allowed for kind of this built-in ability to complete this study in the context of my clinical work and my clinical training that also allowed me to kind of result in some research productivity as well. So I think it comes down to really having this integrated perspective and facing your clinical work with that kind of attitude to find those kind of ways. I think practically, I know there might not be some barriers in a lot of very clinically oriented fellowships. So for some places where, there is kind of a 0% protected time, that might be kind of difficult. And so I would just kind of start with communication with training program directors and really express kind of your thought about what you would like to see in terms of being involved in some research. And if you kind of present it from this integrated way, you might find that there's a better response because it's really kind of coming out of your work with your clinical patients and it's contributing back to your clinical care. So I found that with my training directors, that was kind of a way to advocate for more research participation. That was really helpful.
Thank you for that, Dr. Tan. The next question is related to other barriers. So have you run into barriers publishing as a trainee around needing a senior scientist practitioner support and their name on your paper, for example, or have trainees been able to publish on their own in this field? How do you secure the support that you need to write and publish your research?
Yeah, so that's a really great question. I think a couple lectures ago, I know there was that presentation from No Neuropsychology about being a competitive applicant. And I know, I think if I remember correctly, the median was 1 to 2 publications prior to fellowship. So that really kind of does show that it can be kind of difficult in the field to generate regular productivity. I really found that I was able to be productive even as someone that's primarily clinically focused, really because, as I said before, all of these research studies that I got involved in came out of my clinical practice. And so part of this means that if you are kind of facing certain barriers around time, that you have to spend some extra time, which unfortunately some of us have to choose to do to kind of generate that extra level of productivity. For those that are mentioning barriers related to lack of kind of a senior faculty, I found that because my research was all coming out of my clinical rotations, in which I was being supervised by a faculty member, that it became kind of very a natural progression that they would be involved in the study, and they would be kind of take the role of that senior author. I haven't been in a situation where I've published something without the support of a senior author. I think it just is a lot more streamlined when you do have that support. And oftentimes you need to communicate with them, especially when you need to initiate studies or deal with IRBs, or kind of think about how to practically collect data as well. So my feeling is that it can be really difficult for me to think of a way to kind of initiate your own study independent of your clinical practice while you're in clinical training without the support of that senior faculty member. One other thing I would say is, collaboration is really an efficient way to help with kind of generating that productivity as well. So I mentioned earlier that I did get involved in some collaboration with other colleagues, and that was really an excellent way when you have colleagues that you've identified where you can really support each other's research work. That can be an efficient way to maximize your publishing productivity as well.
Thank you. Those are all really good points. The next questions are related to making clinical practice changes based on research. So how do you decide whether you have sufficient research evidence to warrant making clinical changes in your practice? Is it acceptable to rely on the results of just one study, for example, an RCT, or would you just limit to kind of meta-analytic research in order to inform changes to practice?
Yeah, that's a really good question. So I don't know that there's kind of a established or consistent way to approach this. But my thought is that on the one hand, from taking the perspective of just integrating this perspective as an attitude during your clinical work, we are always generating hypotheses and testing them with our patients and kind of modifying our practice as a response, right? So a very basic example, you might have never worked with a population before and you realize, they don't have the ability to do some of these measures that we're commonly using, then you might change your practice in order to accommodate that. So if you consider, we're constantly doing that in our professional practice, just as a response to the questions that are coming up when we're working with patients and our considerations while we work with them. If we're going to talk about kind of more long-term changes or departmental changes, for example, it's good to kind of gauge kind of the prevalence of these findings in the literature, right? So we always emphasize that it's good to have replication of results or good to see some support of this trend. And usually our studies, kind of come from prior work that has been done, right? So we're kind of answering additional research questions or future research directions as we do our own studies. So in my example earlier with the congenital heart disease study, there had been some limited evidence that there was an increased risk. And so we felt that our study was enough, even though it was one study and probably the first study done in kind of a neuropsychology context in the congenital heart disease population. But we felt that was enough to change our departmental practice. And a big reason why is because it's what we were observing in our clinical work. So me, my supervisor, we were just seeing, autism come up again and again, and we weren't seeing that very clearly delineated in the literature. And so that's kind of why we felt it was appropriate to start changing our practice. If it comes to something where you're advocating for something that's more on a national or regional level or something like that, you really want to consider kind of guidelines or the stance that maybe national organizations are putting out. So, for example, with the congenital heart disease population, there is a national initiative called the Cardiac Neurodevelopmental Outcome Collaborative, and they were supporting the idea of implementing regular standard screening procedures as well. And so, with that support, is how we felt comfortable in advocating for this on a national level. So I think this is kind of a long-winded way of answering this question, but really just thinking about it from a perspective level, that this is something that we're often doing without considering, the magnitude of our, observations or our findings. But at different stages, if we're trying to advocate for change to practice, we might want to consider at each of these levels some of the contextual factors that are in place.
Okay. Next question may be more of a logistical question. How do you, do you include in your patient consent documents that data may be pulled retrospectively and de-identified for research purposes?
So this probably changes from institution to institution. Really, my view is if the IRB, okay, let me back up. Oftentimes, the studies that we're doing are retrospective chart reviews, right? I think the reason why they're so common in neuropsychology clinical, practices is because that's kind of the extent of time that we have to collect data. And so logistically, I think it depends on the institution, but I haven't seen that you need to specify that on the outset. What you do need to do is, once you decide that you're going to do a retrospective chart review, then you need to contact the appropriate IRB and ensure that that's approved. And then for any future data you're collecting, you do need to start including that in your consent forms when you're working with future patients.
Gotcha. All right, one last question for today. So we got a comment saying that I think everything that you said could very easily apply to people in PsyD programs. Would you agree, and do you have any comments about that?
Yeah, so I think this, this presentation, it was really meant for those in PsyD programs as well, because you're kind of coming from training backgrounds that might traditionally be very clinically oriented. And for many of you, you don't have, for those in PsyD programs, might not have kind of a dissertation or other kind of robust research requirement to really provide that kind of training along this developmental pathway. And so a lot of these recommendations, I would say, are very relevant to you because in those contexts of training and graduate training and kind of your future rotations, you might need to advocate more strongly for these kinds of opportunities if that's your case and if you're interested in research productivity. And I think that really comes out of the main message of today's talk, which is kind of not thinking about it so much the scientist-practitioner perspective as kind of a requirement or as kind of this large process, but really just integrating that into your day-to-day practice as a perspective. That's really kind of a very integrated way of generating research ideas and producing research as a response. And that may be kind of the main way that you find to be involved in research if you're in a PsyD program or a program where the clinical focus is the majority of the focus of the training.
All right, Dr. Tan, we did have one more late breaking question if you're willing to answer. Just take a couple more minutes of your time. Is that okay?
Yes.
All right, so the last question that we will discuss is, do you have any knowledge about conducting research in private practices where there are no IRBs? How might one go about that?
Yeah, that's a good question. So I find that I actually have initiated a study before while I was working in a private practice. So I can kind of speak kind of to my personal experience. But they're always, so this answer might change depending on if you're a trainee, in a research practice or in a private practice, or if you're the practitioner. I find that there still needs to be some kind of formalized process of reviewing your plan for conducting the study. Because to do any research ethically and to abide by kind of ethical standards in the field for producing research, you do have to meet certain minimum requirements ethically, including kind of ensuring that you're properly consenting patients, that you're providing them with knowledge of risks and benefits, and that you're very clear about the methodology that you're going to be using and the way that you're going to be collecting data. There always does need to be some kind of review of your plan in order to kind of abide by the ethical standards. So in my case, when I was in a private practice working as a psychometrist, and I wanted to initiate a study, a quote unquote IRB kind of board was put together in the context of the practice in order to review my proposal and kind of ensure that I was meeting a certain ethical standard in terms of my research study ideas, and that way ensuring also that I was complying with all these standards as I moved on with data collection and conducting the study. If you're talking from a perspective that there might not be kind of the members there to kind of constitute a board like that, I know that there are some other ways that you can find institutional boards externally. So if you're in a private practice, that may mean kind of contacting a board that is external to you, either in another institution or hospital. And it would just mean that you're kind of making sure that you're taking the appropriate steps to have review of your proposal, your proposed procedures, to ensure that you're kind of meeting those ethical standards. So I know that there are ways that you can do that. I think it's a good thought to ensure that you consider some of those practical obstacles before you kind of jump into official research studies, especially in a private practice setting.
Great. Thank you so much, Dr. Tan, for your talk today. And we look forward to seeing everyone next Monday. Thank you, everyone.